Hi, everyone. Welcome. It is 30 days and counting till the exam. Thank you all so much for joining us today. I am Angela Love-Zaranka, Program Director at LER.
And I am Sekeita Lewis-Johnson, Accredited Provider Program Director here at LER. Thank you and welcome to this 30-day and counting live with us. I am so excited that you have made it to this point, as you are, I'm sure. So hopefully we can get together today, answer some of your questions, and send you on the way to feeling so inspired and ready to knock this out the box.
Exactly. That's exactly what we want to do. So we've got all of our books here ready for us. We're going to go through a little bit of content. First, a little housekeeping. So if you'd like to ask some questions to us, take a look at the GoToWebinar platform. If you see that blue arrow, you're on a desktop computer and you are using the interface and it looks a little bit like this, then you can take a look there and see where to ask those questions. If, though, you are using your mobile device, take a look at that green arrow and it's showing you a question mark near the bottom. That's where you can ask your questions. You can practice with it now by letting us know where in the world you are listening to us today. We also have Kim and Julie on the call. They are both IBCLCs and have taken the exam most recently. They're part of our fabulous customer support team. And Jill from our incredible tech team is also on the call. So if you have any tech issues, please type them into the Q&A box and we will try to find a solution, or they're going to flag things so we can answer them during the webinar. Now, we are going to ask, please don't photograph or record this information with a camera, a phone, or any other equipment. We are recording this, and you will be able to review this session as many times as necessary. And as I mentioned, we will be answering some of these questions at the end of the session. Okay, so first, we are going to start with medications. Sekeita, that one is yours. You're up.
I am up, so thank you, Angela. So we're going to kick it off with medications, and I want you all to just kind of relax, just lean into this. One of the key things to note is that you will receive handouts about the medication section. So please, you can put all your pens down. You don't need to like cramp your fingers, but of course you might want to take some notes, but just know that this section, there will be a handout for you regarding the medication. So it's important to remember that the amount of medications or drugs excreted into milk depends on many factors. And we're going to review some of those factors here today. Let's start with milk to plasma ratio. It's useful to evaluate the relative concentration of medication in the plasma compared to milk. And then when we look at the relative infant dose, it's a very important clinical parameter to determine safety. It usually is expressed as a percentage of the maternal or lactating person's dose. And according to HEL, in medications in mother's milk, medications with a relative infant dose less than 10% is considered relatively safe for a full-term infant. Notice I said full-term infant. I really want to be clear about that is the kind of clarifying term in all of this. So a relative infant dose greater than 10% for a full-term infant should be cause for further assessment of the situation. And it's not to say that, oh, it's just out, but it's just another cause to look a little deeper and make sure that we are recommending this medication or thinking about this medication in a way that it is safe for the infant. Moving on to oral bioavailability, this refers to the ability of the drug to reach the circulation after it's been taken, after it's been ingested. Drugs with a low oral, I don't know why this is a tongue twister for me, low oral bioavailability are generally poorly absorbed in the infant's GI tract, or they're destroyed by the liver prior to entering into the infant circulation. Or they're taken up by the liver, sorry. So keep in mind that, all of these factors are key when you're thinking about medications. And I also want you to think about this. Think about kind of knowing the concepts, not remembering the concepts. And when I say that, as it relates to practice, as it relates to, being given a scenario and what would you do type of situation. Keep in mind that medications enter the milk compartment only from the lactating person's blood or the mom's blood. So if it doesn't reach the person's blood, it does not reach the milk. The other key thing is to remember that during the colostrum phase, medications do transfer into milk more easily due to the large gaps among the alveolar cells. With that being said, though, even though it transfers more easily, the total dose transferred to an infant is very low due to the limited milk volumes of colostrum. And so you also want to keep that key principle in mind. The other key thing to note is that most medications enter the milk at clinically insignificant levels. So when we're thinking about the levels, you also, and this is a practice pearl, I would say, you determine the levels in the milk, the relative infant dose, as well as the lactation risk category. Now, I mentioned Hale, and I'm going to talk a little bit about Hale's classification, but there are other classifications and other sources where you could get your information, and you might have another source that you're using as it relates to medications and lactation. You do want to be cautious of high vitamin doses, always. And the other key point to remember is to avoid sedative drugs, opioid narcotics, radioactive agents, chemotherapy or anti-cancer drugs, and high doses of iodine. So just for another review and another, I guess I should say, subset of key points. Remember that drugs may transfer into the milk if they have large concentrations if there are large concentrations in the person's blood, in the parent's blood. If they have low molecular weights, if they have low protein binding, and those that pass easily to the brain. Conversely, you want to choose medications that have short half-lives, high protein binding, or high molecular weights. So we're going to move into some specific medications classes. And, when we're talking about these classes, I want you to make sure that you remember you do not have to memorize the L ratings that's here on these tables. They're here for the tables, as a point of reference to you so that you kind of get an idea of where they fall along the category. So you won't be tested on whether a medication is a L1 versus a L2 or L3 or L4. However, you are expected to know true contraindications, or I would say high caution areas of medications, such as your chemotherapy medications, such as your iodine and things of that nature. But we're going to begin with just some common classes. And so we're going to start with antibiotics, which are commonly prescribed. And many providers and clients will often have questions about their safety regarding breastfeeding and chest feeding. So as a general rule, antibiotics are compatible with breastfeeding or providing human milk. The one thing to note is that there are concerns that they're just not benign. You can have changes in the gut flora, or sometimes there's some antibiotic resistance that can occur. Those are just the major concerns that happen with antibiotics. And that's across the board. That's just not with infants, that's also with adults. With Cipro, though, ciprofloxacin is noted to be an L3, and it has been associated with GI problems. So if you're not familiar with the name of the many drugs, if you look at this chart, it might be helpful to know that most antibiotics end in CIN, as in ampicillin. And that's true for many, but not all antibiotics, right? But it's just to kind of give you a hint on if medications is not your strong suit, a way of looking at a question and perhaps being able to deduce what you're being asked based on looking at the actual name of the medication and the ending. Antifungals. All right, let's dive in. Antifungals, if you've been reading any of the literature about what's happening with yeast and all these other fungal infections, it can be confusing in a clinical sense, in a practice sense. But these drugs are used for fungal infections such as yeast and other fungal infections. Thrush is being called in the question, but if you see a question about thrush, please note that the parent should be treated simultaneously as the infection can pass back and forth between them easily. I don't know if you'll see a question about thrush, honestly. However, I will say in practice, topical antifungals such as nystatin or miconazole are used to treat yeast and are considered safe as long as minimal amounts are applied to limit the oral absorption by the infant. Okay. So that's it about antifungals. I just want to be clear that I don't, you should be familiar with antifungals. Some of the literature is saying that what we thought was yeast are now bacterial infections. And so it'll be interesting in the next few years what's going to come out. But I just felt like I needed to disclose that piece too. So, brush up a little bit about how to treat or get to what we think may be bacterial infections versus fungal infections. Analgesics. Analgesics are pain medicines. And for the most part, I believe many of us know that after delivery, they are common. They are commonly used. The class of medications, this class has various compounds that makes many of them, or some of them, I should say, not many, some of them incompatible with providing human milk. Take, for example, Tylenol. Tylenol is an L1, which is compatible with providing human milk. However, if you combine it with codeine, it's potentially hazardous because codeine is an L4. And according to HEL, y'all bear with me today. According to HEL, an L4 is a classification that indicates that a medication is possibly hazardous. So there are individuals who have a genetic trait that make them rapid metabolizers of codeine. So the FDA and numerous drug advisory groups advise against the use of codeine during lactation. Going on to Motrin. Motrin is a non-steroidal anti-inflammatory, which is an L1. You can see aspirin is an L2, and then there's a caveat with aspirin. With aspirin, it's not safe to use when the infant is sick or has a fever because of its association with Reye's syndrome. Also, morphine is a potent analgesic and is classified as an L3. It's used like in the spinal cavity for C-sections. It's also used postpartum for surgical pain management, and it appears to be safe for limited use. And keep in mind that all narcotics should be used for short time frames. Additionally, you want to note that the compatibility of medications, particularly analgesics and pain medications, the compatibility it only exists if they are being used as prescribed. So for example, and I want to say this in another way, if they are not being used, if they're used more than what they're prescribed, then you want to be able to note that the compatibility of providing human milk may be in question. The other key thing I want to point out with this class of drugs is infant concerns can be signs of sleepiness, lethargy, poor feeding, inability to wake the baby for feedings. Those are concerns that you may have with certain pain medications. Anticonvulsants or anti-seizure medications. This was always a tricky one, as for a lot in practice. There are people with seizure disorders, and because it's something that happens that's rare, people are up in arms about whether or not someone can provide human milk or breastfeed their child on this class of medications. There is one in question, which is Depakote. It is under the L4 category as possibly hazardous. However, the other medications are classified as L2, L3. They are not contraindicated. They do require extra precautions of monitoring the infant, making sure you're monitoring for infant sleepiness, poor feeding, irritability. Another drug that, interestingly enough, during my practice, it used to be magnesium sulfate was contraindicated to providing human milk. And whoa, that's interesting that it's classified as an L1. It's used to treat preeclampsia. So this is a medication that may be seen more times than not than the other ones. So just keep in mind that it is an L1 and it is compatible with providing human milk. Antidepressants. These three antidepressants appear to be compatible with providing human milk. We know that postpartum mood disorders are common. And so there are some conditions that do and will require medication management. These medications are listed as L2s, as limited data, probable compatibility. And according to HELS, medications in mother's milk, Zoloft seems to be the preferred. However, keep in mind that there has been controversy on the safety and compatibility profile of antidepressants. However, when we're talking about this important topic, it's important to remember the risk-benefit ratio. Infants should be monitored for sleepiness, poor feeding, and low muscle tone, as well as agitation. The other thing I want to say, something that if you haven't registered as I've been going over the infant concerns, almost all of the infant concerns when we're thinking about medications fall along the sleepiness, poor feeding, irritability, low muscle tone, agitation, those sorts of key things. So if you can put those all together and kind of remember that there's two parts to this, the safety profile as well as what's happening with the infant, you could kind of put the puzzle together easy. Moving to antihypertensive, which is your medications for blood pressure. Again, this is a category that is generally well tolerated and accepted for lactation. These medications, if you look at them, the other when I talked about what's in a name, it might be helpful to remember, for example, the actual drug name and then the common name. You don't have to remember those. I would say remember the drug actual name. If you look at labetalol, metoprolol, propranolol, you can see they are a class of antihypertensive. Atenolol is still there. If you also looked at captopril and lisinopril, these are things that can help you easily identify what kind of medication might they be talking about. Nifedipine or nicardipine is there. The very bottom of the portion, when we're talking about hydrochlorothiazide, which is sometimes you can see it as HCTZ or furosemide, this class of medication is considered diuretics, which means that they kind of, have the drying effect to get rid of fluids, to flush fluids out of our bodies. And with that being said, I put an asterisk next to them because they do have the potential to reduce milk supply. When we move on to infant monitoring, just know that some of the same concerns of sleepiness, lethargy, pallor, poor feeding exist also with this class of medications. All right, vaccines. Generally speaking, vaccines are safe while breast and chest feeding. The yellow fever vaccine is not recommended. The smallpox vaccine, according to Lawrence and Lawrence, the smallpox vaccination is inadvisable for the mother of any infant younger than 1 year of age, nursing or not. The personal contact, not the breastfeeding, causes the risk. Therefore, no advantages exist to weaning if vaccination is necessary. This vaccination is not given routinely and is rarely indicated. So, before moving on to Angela, I just want to make sure that I take a pause here and try to clear up or answer anything that I may have fumbled over or that you may have questions on. Angela, here you go. What did I mess up? Let's see.
I mean, you didn't mess up anything, let's be real. But somebody did ask if you could define high doses of vitamins. And I don't know if you've got a quick answer to that. I've been diving a little bit into, for example, Dr. Hale's halesmeds.com, and that's not the only one, right? There's eLactancia, which is a really good resource. There's also another group called Otis, OTIS. Julie, could you put that link? Sorry to put you on the spot, Julie, but can you put that link in the chat? That Otis recommendation, Julie told us about this. It's available in the United States, and it's a free service for medications, is similar to eLactancia. And I'm just taking a look at these different vitamins here. For example, vitamin E, vitamin A, different vitamins, vitamin C, different vitamins. What's considered a high dose is going to depend upon a lot of different variables, whether or not it is water soluble, as well as whether or not there's a buildup and what the harm could be if there is a higher than usual dose, which is used over a long period of time. And so those are the different things that you want to consider when talking about high doses of different vitamins. Is there anything else, Sekeita, that you wanted to add to that?
Yeah, when I think about high doses, I think about like anything over recommended. When I think about vitamin C, I believe it's 1,000 milligrams a day, right? But I do know that in certain instances, in certain conditions, high vitamin doses might be recommended for certain individual, which means anything above what the average, what the actual dose per day. Every single medication out that is prescribed has a max dose per day that can be taken, even Tylenol, right? And so when I think about high vitamin doses, it's really looking at, you know what, if the recommendation is 1,000 milligrams per day, and I'm just giving this as an example, and your client perhaps have been prescribed 2,000 milligrams per day, that might be pause for kind of looking at it a little bit deeper and seeing. The other thing is it depends on the route. If somebody is getting IV vitamins at high doses, that's also something that is not out within the norm. Now, do I think you'll be asked a question about that level of detail? Possibly not. I think it's just knowing that if you receive a question about high vitamin doses, that you're aware that that is cause for concern, and really read that question carefully. That's how I'll answer that. But it's impossible to know what a high dose for every single vitamin is. It's impossible also to know what what are the indications. Like my practices, I learned from a family practice perspective, and not, for example, a cardiologist or neurologist. Like there's so many conditions that someone might be prescribed higher doses of vitamins that it would probably be really like hard to take a deep dive. So just know that that is what's recommended. I will also too want to make note that this the presentation that you just heard came out of Hale, and also what was my other reference? Lawrence and Lawrence. I'm sorry. I was like, I just mentioned.
Yeah. Yes,
And
yes.
so those are the references that I use particularly for that portion of the presentation.
Right. Do you have your Hale with you, Sekeita?
It
Because
is.
someone is asking about antipsychotics. So again, I think, yeah, go ahead.
Yeah, my Hale is, I can go into antipsychotics. Let's do this, Angela. You want to start on your section, and then once you end, what I'll do is I'll come back and address antipsychotic medications.
That's good.
That's a great question, and I appreciate you for that. And thank you, because I think I need to add that to this presentation. So whoever has it.
And someone is asking about high versus low molecular weights transferring into breast milk. I think taking a look at Dr. Hale's website or doing a deep dive yourself into that piece may be something to help to remember that. Go ahead, Sekeita.
I do want to say this. I have seen a range between 600 and 800 as far as the molecular weight. And this is the thing. I did not, it's interesting because when we think about molecular weights, that range to me seems to be like a wide range. However, when we think about pharmacokinetics, it might not be such a wide range, right? But as far as less than, it usually, back in the day, my reference was less than 800. And I also believe that Julie had something to add the last time about this, and she was able to get some information. But I believe it's between that 600. I've seen different ranges now, and so I want to be cautious in saying and giving the actual molecular weight in this instance.
Good.
But
And I'm going to go ahead and
look that up again too and see if there's new information out. But that was the last time we did this, which was in March. I believe that was the thought process.
Right. And someone is saying, and I'm going to go ahead and you start looking things up. Someone is asking a question about smallpox. So according to Lawrence and Lawrence, page 391, smallpox vaccination is inadvisable for the mother of any infant younger than 1 year of age, nursing or not. The personal contact, not the breastfeeding, causes the risk. Therefore, no advantage exists to weaning if vaccination is necessary. This vaccination is not given routinely and is rarely indicated. So you can take a look also at the CDC website if you'd like more information about that. So, okay. So as Sekeita is looking things up, let's see here. Let's go to breastfeeding beyond that first month. So there are different maternal concerns, fertility, tandem nursing, weaning, things like this. So we're going to go through some of these other issues that may or may not be as familiar to you. So in counseling clients with older nurslings, be mindful that the number of feedings and the time at the breast may fluctuate greatly. Babies might return to intense breastfeeding to adjust their parents' milk production as needed, which is sometimes referred to as growth spurts. They often occur around 2 to 3 weeks, 6 weeks, and 3 to 4 months. Now, developmental milestones may increase night waking and nursing. Sometimes these little ones are just too busy exploring their world during the day to spend time at the breast. They may miss something if they do. Therefore, they may wake more frequently at night in order to receive the caloric intake they intrinsically know they need. Latch and position techniques are much more flexible after those first few days and weeks and even months. Note in the picture here that the baby is further away from the breast than when a newborn. Now, unless the parent's uncomfortable, there's no reason to suggest changing the position or the latch. Breast and nipple pain are two challenges that some parents face while lactating. This is one portion of a 13-page algorithm developed by UNC for breast and nipple pain. It's a very valuable resource, and it's a good review prior to the exam for how to identify many of the causes of breast and nipple pain. So take a look. The link is here. It's also included in your handout. Now, mastitis is an infectious process in the breast that produces localized tenderness, redness or discoloration of the skin, and heat together with systemic reactions of fever and malaise. Prospective studies estimate the incidence between 3 and 20%, depending on the definition and the length of the follow-up postpartum. Technically, mastitis is an inflammation of the breast, which may or may not involve an infection. The problem can begin with engorgement, then non-infective mastitis, followed by infective mastitis and to abscess if treatment is not introduced properly. So symptoms include fever of 38.5 centigrade, which is 101 Fahrenheit, chills, headache, flu-like body aches and symptoms. The breast is painful and swollen. The breast area is red or hot or tender to the touch. The parent may notice some red blotches, some streaks, discoloration, bruising of the breast tissue. Treatment includes rest, continue to feed and or pump on the affected side, cold compresses to reduce edema, creative nursing positions, breast movement or breast gymnastics as demonstrated by Maya Bowman. Her website, mayabowman.com, is phenomenal. Support compliance if antibiotics are prescribed, and use analgesic or anti-inflammatories for discomfort, fever, and swelling. Now note, I intentionally chose this picture to try to help you to see mastitis. It can be challenging to note overt inflammation or redness on someone who has darker skin tones. And yes, I know some people are probably asking now whether or not the new mastitis protocol will be included on the exam. While we don't know, I think it's important to be familiar with what those recommendations are. So recurrent mastitis, so Staphylococcus aureus is cited by Dr. Ruth Lawrence in her book, Breastfeeding, A Guide to the Medical Profession, as a common cause of breast infection. Jimenez found that Staph aureus dominated the microbiome of mastitis sufferers. However, Staph aureus was found by other researchers in the milk of asymptomatic women. In the case of recurrent mastitis, the diagnosis can be made with a culture of milk and infant nasopharynx or oropharynx swab. Treatment options and a thorough discussion of mastitis can be found in the Academy of Breastfeeding Medicine's protocol on the mastitis spectrum. So breast abscess, a small percentage of infections will develop into an abscess. Kinley reported the incidence somewhere around 5 to 10%, whereas EMEA reported about 3% of women with mastitis in her sample developed an abscess. One theory is that healthcare providers are more educated in the prevention of abscesses. Dr. Lawrence reports an increase in abscess rate when antibiotic treatment was delayed beyond 24 hours. An abscess is a localized collection of pus that forms from an infection that has no opening for drainage. The indications for an abscess are the same as mastitis, although the symptoms may be less severe because the abscess is isolated from the rest of the breast. This picture demonstrates an obvious abscess. Occasionally, an abscess can occur in the absence of any systemic symptoms. And usually when the antibiotic treatment has been delayed beyond 24 hours, the abscess rate increases. So treatment options for smaller abscesses, so less than 3 centimeters, the recommended first line of treatment is fine needle aspiration, single or repeated, preferably under ultrasound guidance. For abscesses greater than 3 centimeters, a percutaneous suction catheter can be placed for 3 to 7 days with oral antibiotic effective against penicillin-resistant staphylococci for 10 days. And for larger abscesses, the healthcare provider will incise and drain the area. A drain is placed to promote drainage. The incision heals from the inside out, so usually that may take a week or two. The parent can continue to nurse on one side or both breasts depending upon the location, the associated pain, and medication. Although a very small percentage of women resume menstruation as early as 6 to 12 weeks, others may not menstruate until breastfeeding has ceased totally. It's usually dependent on overall breastfeeding patterns. There's no significant change in the composition of milk when the menses returns. Hormonal changes may alter the taste of the milk, which can prompt the baby to be fussy or refuse to nurse. Some mothers feel that it may temporarily lower their milk production. It may also impact a family's child spacing plans, especially if they were relying on the lactation amenorrhea method. So nursing through pregnancy. So pregnancy while nursing can occur. Explore the parent's feelings about continuing the breastfeeding. Some women will note nipple and or breast discomfort. Some report the discomfort alerted them to the new pregnancy. Now, depending on the age and nursing relationship, some nurslings may be reluctant to wean. Mature milk will change back to colostrum, usually around 4 to 5 months into the pregnancy, which may change the taste and quantity of the milk. Oxytocin is released during nursing. However, the oxytocin is blocked by progesterone. There's no need to wean a nursing baby or child unless there is a true risk of preterm labor. There's limited data that shows an impact to the mother's nutritional status by continuing to nurse through the pregnancy. Therefore, it's important that the mother is mindful of their diet. Some older babies or toddlers may stop during the pregnancy or resume after the birth of the baby. So tandem nursing is the term to describe breastfeeding of 2 or more children who were not born at the same time or are different ages. It occurs when a parent nurses through a pregnancy or if a previous child weaned during pregnancy may be interested in resuming. It's very important to explore the mother's feelings about tandem nursing. As one of the pioneers in the lactation field, Shelley Marmette, once said, it takes the patience of Job to tandem nurse. Now, if there's an issue with the infant's weight in the early days, ensure that the newborn is given priority at the breast. Some mothers will dedicate one breast to the newborn and the other to the toddler and switch the next day. Note here the way the older sibling has her arm around her new brother. Granted, it may be so everyone can fit on mom's lap, but it may also be a sign of affection. That's my take on it. Now, weaning. If a parent expresses a need to wean, explore their reasons once again. Some families believe that weaning may increase a child's independence or help a child sleep more at night, which may not be achieved through weaning. Gradual weaning works best for both parent and baby. It reduces the risk of severe breast pain and mastitis. In several texts on nursing a toddler, the first suggestion is don't offer the breast and don't refuse a child's request to nurse. Eliminated feeding every 2 to 4 days, preferably not back-to-back feedings. Continue as both the parent and the child accommodate to the new routine. Hand express for comfort as needed. Change daily routines for the child so that alternatives to nursing are offered and explored. Offer other foods and drinks just before the regular nursing sessions. Breastfeed when asked, but for shorter periods of time. Now, let's take a look and see if there are any questions in this section before we pop into milk supply. Sekeita, is there anything there? As I open up the questions here.
I have been just going back and answering some of the flagged questions.
Great, perfect. Okay, good.
To stay up to date and you know, found my information about antipsychotics.
Right. And so most, somebody asked a question earlier about contraceptives. Most contraceptives are compatible with breastfeeding. The goal is, and please correct me if I'm wrong, Sekeita, the goal is to try to hold off until lactation is well established prior to starting hormonal contraceptives. Is that still the case?
Progestin only oral contraceptives is what is preferred. And even there's some interesting literature coming up about that as well. So progestin only, preferably waiting to at least 6 weeks postpartum before introducing any type of contraception, simply because there are certain contraceptives that once you give them, you can't get it back. And there is and even ACOG, which is the governing body for obstetricians and gynecologists, recognize that the way they quote it is that there is a theorized risk of low milk supply. So whenever you are going to kind of question whether or not, you know, someone may not meet their goals for extended or long-term infant feeding, you really want to make sure that they understand some of those risks associated with contraceptions. And I'll leave that there.
It's very important. It's very important that all parents, that there's a good, robust conversation between the prescribing provider and the parent, and that lactation is something which is considered very seriously. So that's good. Thank you.
I want to answer one question because I said something in Hill's book, the latest one that I have. It says that drugs may transfer into human milk if they are low in molecular weight, which is less than 800 Daltons. And so that still is the number that I have here. The other thing is there is a table in the back of Hill's book about antipsychotics. And generally speaking, the antipsychotics are the commonly used atypical antipsychotics. And again, I will be adding that to this presentation going forward. There is one that I think is very interesting. And I'm going to put it in probably the chat. Is that the best way to do this, Angela? Because I want to make sure that the name is spelled correctly. But for the most part, they're classified as L2s with the exception of a couple, but there is one that may suppress prolactin levels. And I was like, whoa, that would be good to know from an antipsychotic standpoint. And so I will be putting that in the chat. I just wanted you all to know those two updates. Also, my reference in Hell was interesting about the high vitamins. That's exactly what Hell said. High vitamin dosage. That's a direct quote from the literature here. And so I apologize if I can't be more helpful than that. But that's the update on those few questions that I found. And then I'll get busy with putting the antipsychotic in the chat. And also I will continue to answer questions. Angela.
Thanks, Sekeita. Yeah, and just one thing about, yeah, I'll keep going. One thing about the vitamins and using high doses of vitamins, you know, one would expect that the person would have some sort of a healthcare provider who's giving them the information on that they're not just Googling it and finding something and says, oh, I should take high doses of vitamin A or vitamin C. Oh, it's supposed to be good for you. By all means, they should really be talking with a healthcare provider who's knowledgeable. And that could be someone who is knowledgeable in complementary and alternative medicine. It could be a functional medicine provider, integrative medicine provider, Ayurvedic practitioner. So there are many different things before someone undertakes, you know, taking high doses of vitamins. The question to ask is why, and where did they get the information before you say yes or no. So.
Yeah, there was another question about medications that I did answer in the chat, but I do want to make sure I acknowledge it live. The question was related to whether or not lactation consultants could recommend Motrin. And the answer to that is that if a medication has already been prescribed by a prescriber, you know, what we should know about it is the safety profiles. What we should know is if family mentions a drug to us, that we have the resources, that we can point them to the resources if we don't have the resources to get the adequate safety profile information. The reality is not even all clinicians, as Angela just spoke about, may not know the safety profile for lactating individuals as it relates to medications. And unfortunately, a lot of people are given information that they should just pump and discard their milk. So as advocates of and protectors of lactation, we should definitely know about the safety in finding resources on how to find the safety and give families the information. However, no, we don't recommend or prescribe if you are not licensed to do so. So I hope that answers that question.
That's perfect, Sekeita. Thank you for the reminder. Appreciate it. Okay, so now milk supply. So we're going to take a look here at this neuroendocrine reflex arc. And yes, we are going to move quickly, and do note that all of the slides are not in the handout, and there's a reason for that. And so we've put the most impactful slides as part of the handout. So once again, please don't take any pictures or record this presentation. You can listen to it later. So this is the neuroendocrine reflex arc. Just to remind you of that physiological mechanism of lactation, milk synthesis is a complex interplay of the hypothalamic pituitary gonadal axis. Milk synthesis is related to the degree of breast fullness. Suckling or expression or other nipple stimulation stimulates prolactin secretion and the release of oxytocin. It is milk removal that enables milk secretion to continue. So this is a slide you may have seen in the anatomy and physiology, as well as in the relactation exam reviews. According to Margaret Neville and Jane Morton, failed lactogenesis can be described as preglandular, glandular, or postglandular. An example of preglandular would be hormonal causes such as retained placenta or lack of pituitary prolactin. Glandular causes might be surgical procedures, such as reduction mammoplasty or possibly insufficient mammary tissue. That's glandular. Postglandular would be any cause for ineffective or infrequent milk removal. These include some of these iatrogenic causes of lactation failure are those which have been impacted by policies and procedures in a hospital or by healthcare providers, which can have a negative impact on milk production. A parent's perception of milk supply in the early hours and days after birth could also be considered postglandular. So some of these iatrogenic reasons for lactation failure is separation of the parent and the baby, pacifier use. As mentioned in the previous slide, perceived insufficient milk by staff or family, which leads to supplementation. Interventions which require supplementation and milk supply, which is not simultaneously supported through hand expression or pumping, can be a postglandular reason. And you sort of consider that supplementation scenario, right? The parents are told they have to supplement their baby, and some parents may feel that they have failed breastfeeding, or they're scared to try to resume breastfeeding. And well-meaning healthcare providers may not encourage the resumption of breastfeeding if the interventions are effective. So this is a common scenario. Let's say a baby has been diagnosed with hyperbilirubinemia in the early days, and supplementation with breast milk substitutes has been begun, or a 2-week-old baby who wasn't gaining effectively and begins to gain with supplementation. In both cases, you can understand that the parents may be afraid to resume exclusive breastfeeding, chest feeding, or human milk feeding, and healthcare providers may not have the time or the capacity to create a care plan to help the baby to return and to direct breastfeeding and or exclusive breastfeeding and or removal of the supplementation. Finally, another post-glandular reason for insufficient milk removal could be some cultural beliefs that create a barrier to normal breastfeeding, such as colostrum is not enough or is bad for the baby. So breast or chest tissue anomalies include surgical interruptions in the breast or chest region, biopsy, reduction, or augmentation, chest tube as a preterm baby or thoracotomy prior to mammary development, mammary hypoplasia or insufficient glandular tissue, mammary asymmetry, including intra-mammary distance or the space between the breasts. Chronic illness can impact as well. So milk supply, so hyper or hypothyroidism, lupus, Parkinson's, diabetes, hypertension. Acute illness or birth-related complications include hemorrhaging after birth, especially causing a sudden drop in blood pressure and or requiring blood transfusion. Now, as a point of reference, 500 milliliters of blood loss is considered normal. Hemorrhage may cause damage to the pituitary, ranging from a mild insult to major infarction. Sheehan syndrome is a severe hemorrhage and drop in blood pressure that may result in necrosis of the anterior pituitary. Hormonal issues such as irregular menses, infertility, obesity-related issues, PCOS, weight loss surgery, specifically gastric bypass surgery, which can impact the amount of nutrient absorption. Other factors for delayed lactogenesis 2 greater than 72 hours include premature delivery, insulin-dependent diabetes mellitus or gestational diabetes, metabolic status or health refers to an interesting study from Nomson Rivers, which describes 3 risk factors for delayed lactogenesis, which include higher BMI, increased maternal age, and larger infant birth weight, as known correlates with carbohydrate intolerance and systemic inflammation. And I would be remiss if I also didn't mention fat phobic bias and staff who are unaware of their bias and do not provide the clinical care and support that parents need in those early days after the baby is born. Other factors include hypertension, high levels of stress to the mother and fetus during birth, cesarean birth, especially when it's urgent, prolonged stage 2 of labor, which is greater than an hour, augmentation of labor with intravenous oxytocin, forceps or vacuum delivery. Now, if the timing of the first breast stimulation following delivery is greater than 6 hours, that can impact and delay lactogenesis 2. Significant edema of the extremities, endocrine disturbances. As you can see, there are complex interactions among the various factors that may affect lactogenesis. Whether the delay of lactogenesis 2 is a maternal physiological response due to delayed or ineffective suckling or a combination of factors has not yet been clearly identified. Early, frequent, and effective breastfeeding appears to be the most important factor in establishing normal lactation. Now, I'm going to argue that skin to skin and milk expression in the first hours after birth as key factors to counter the possible risk factors. Those of you who work in a hospital setting can understand how that might be impeded with any of the above diagnoses. Any issues which affect sucking or suckling frequency may affect the initiation and calibration of milk production. The baby may not be capable of sufficient milk removal to initiate and maintain an adequate supply. Important factors include gestational age, premature infants, of course. Remember that late preterm infants may not suckle well enough for adequate milk removal. The infant's oral and facial anatomy. Any tongue mobility restriction can impact not only maternal nipple discomfort, but also the ability to remove milk. Palatal issues, obviously, including a partial or complete cleft of the hard or soft palate, but it also includes a high, bubble, or channel palate. And airway issues, including laryngomalacia or tracheomalacia. Long-term, the issues on the previous slide can impact the initiation and calibration of milk supply. The following can impact the maintenance of milk production, such as in the immediate postpartum period, infant hypotonia or hypertonia, birth trauma pain such as shoulder dystocia or use of forceps or vacuum, cardiac or respiratory issues. Long-term impact could include infant facial anomalies, the tongue, the palate, and sensory integration issues. Now, here are a few solutions to get off to a good start with building the milk supply. During the hospital stay, frequent skin-to-skin contact, you can't overdo this. Frequent colostrum and milk removal, hand expression does seem to work best. A quick note, for parents who are pumping for their premature infant or are having trouble extracting an appropriate amount, utilization of the other senses can help with the milk ejection reflex. A study noted an improved milk output when the mother was looking at pictures of the baby and or listening to the baby's coos or cry, as well as smelling their t-shirt or blanket from the day before. Anticipatory guidance about newborn normal circadian rhythms, visuals of the newborn stomach, and the nominal nutrition requirements in the early days. Realistic expectations are another good solution, and alternative supplementation techniques if they are required, and of course, close follow-up. Okay, now, are there any questions about this section? Sekeita?
I believe that you have done a phenomenal job, and I think
We're good?
one popped up. Hold on. I guess I should clarify my question. Can you differentiate the difference between preglandular, abdominal glandular reasons for delay in lactogenesis 2?
I'm not sure what abdominal glandular reasons are,
Yeah.
but the preglandular and the glandular. So glandular, anything that affects the breast, chest, trunk, parenchyma, that area. So any sort of surgery, any sort of thing which disrupts it, the intramammary distance, the inframammary fold, things like that. So that is the glandular piece of it. Preglandular are things that happen prior to birth. So for example, a pacifier use is going to be postglandular, but a medical diagnosis of hypothyroidism, right, Sekeita, would be a preglandular. Yeah, so that's sort of how you know. And I have a feeling that on the exam, it's probably not going to say which one is preglandular, postglandular, and glandular. I don't think that's probably going to be it. I think it's just important to note the different reasons why milk supply could be impacted. Would you agree with that?
Yeah, I also do, though. I don't know if I recall. I don't know. Just know about keep those words in your bank. Preglandular, know what they are, what they mean, what types of indications are for it, for each. And so, yeah, Angela, I was just about to ask that question. You already answered it, so great.
Great.
Other than that, I think you're up to date.
Okay, let's keep going then. We're going to talk about research, and then I think we're up for some questions. So let's find out, Sekeita. Okay, so as far as research is concerned, so now we're going to talk about just some of those key phrases that you should be aware of. So the dependent variable is what the independent variable acted upon. In a study on breast pumps, the volume of breast milk obtained when using several types of pumps was compared. The volume of milk is the dependent variable. The type of pump is the independent variable. Consider what we know about the effectiveness of pumping. It can be impacted by a number of factors. Therefore, confounding variables in this example might be the privacy of the place where the parent pumped. That might lower the amount they're able to extract. Or the time of day could also be a confounding variable. And I just want to review quickly some frequently used terms. So the standard deviation is a measure of how spread out the numbers are. 68% will fall in the first standard deviation, you see with the green here. 95% will fall into the first and second standard deviation. If you're seeing this in color, it's sort of a light blue color. And 99.7 will fall into the first, second, and third standard deviation. So there's just going to be a few in that fourth standard deviation, which is the purple here. So, or actually beyond the purple. So statistical significance is the level of certainty in the study, in the results of a study. If we want to be 99% confident of our results, we set the significance level at 0.01. If we want to be 95% confident of our results, we set the significance level at 0.05, which is most medical research. Bias. There are different types of bias, and it can influence research. For example, a piece of research that looks at the effectiveness of a breast pump, specifically the frequency of the number of cycles per minute. You note the university who supported the research is funded by a specific breast pump company. The researcher whose university receives funding from a pump company could be biased in their study design and/or the interpretation of their results. Informed consent. Subjects need to be informed about their rights, equipment, or medications used, procedures, confidentiality, and how to withdraw from a study at any time, as well as any rewards for participation. Okay, now, next, we're actually going to go into the questions. Now, I'm going to ask you all a few questions to see how you do, and I have to be really honest, Jill. I do see that the polls are ready to go, which is great. You and I did not have a moment to chat about it, but I know this well-oiled machine is going to be ready. So what we're going to do here is I'm just going to talk about a few of these overall concepts, and keep in mind that some of the overall concepts that we're going to review, they do have specific applications. And so hopefully you'll be able to take the information which is in the question and have the information that you need in order to answer the questions. I'll leave the slide up for a moment, and then Jill is going to pop the survey, and you're going to be able to answer in the survey as far as which answer is correct. And so then we'll leave it open for maybe about 25 seconds. So don't take too long, 25 to 30 seconds. You'll have longer on the IBLCE exam. But in order to respect your time today, let's go ahead and move forward and see what these questions are. Okay. So here's a question. Physical breast presentation, which may contribute to low milk supply, is significant inframammary fold, breast cup size, which is less than a B, significant intramammary distance, or hypoplasia of the superior breast tissue. So which one of these things could impact or contribute to low milk supply? Okay, Jill. Thank you very much. So the correct answer is C. Most of you got this one correct. Significant distance between the breast, which is also known as intramammary distance, may be associated with hypoplasia. Cup size doesn't matter. Hypoplasia of the superior breast tissue is the upper breast tissue. That does not indicate insufficient glandular tissue. Hypoplasia of the lower medial and lateral quadrants do. Okay, now go ahead, and I'm going to leave this question up here for a minute before you pop it open, Jill. So let's see. A post-glandular reason for insufficient milk production is early introduction of hand expression, pacifier use, retained placenta, previous breast biopsy with periareolar incision. Okay, go ahead and open it. Post-glandular reason. And because of the extra explanation we did, I don't think many of you are going to miss this one. Okay, Jill, I think that's good. So yes, most of you got this correct. The correct answer is B. Pacifier use is a post-glandular reason for insufficient milk production. And I think someone may have seen the first one, early introduction of hand expression, as the possible answer. It's but you remember that you would need to see not, lack of early introduction of hand expression could be that reason, but for the purpose of this, early introduction of hand expression is the answer. And of course, the previous breast biopsy is going to be a glandular reason. All right, so let's go to the next one. Let's see. While reviewing your postpartum patient's chart, you see they received Pitocin, also known as synthetic oxytocin, and Methergin after a vaginal delivery. You know this patient most likely, A, experienced a normal blood loss, B, experienced excessive blood loss, C, gave birth to multiples, D, will not be able to breastfeed. Okay, so go ahead. So they received synthetic oxytocin and methylgonovin maleate. I apologize. I should have practiced that word before we started here. Methergin. I reside in the U.S., and so that's just something where I can say that more easily than I can the generic name. Okay, another 5 seconds here. Again, this is not one that where we fooled too many people. Okay, Jill. So yes, the correct answer is B, experienced excessive blood loss. So just notice how the first line medication used in the management of excessive blood loss during the 3rd and 4th stage of labor is the synthetic oxytocin. Now, if the bleeding does not decrease, a second medication is indicated. So providers may choose among several second line medications, including the Methergin. So A is not correct because the management of a normal blood loss does not require 2 medications. And C is not correct because delivery of twins does not require 2 medications. And D is incorrect because excessive blood loss does not necessarily mean breastfeeding will be unsuccessful. Okay, great. Now going to the next one. Lilo lactation consultant did a study in her hospital. Families were randomly placed into 2 groups. One group received an intervention and the other group received standard postpartum care. What type of research is this? Quantitative, qualitative, historical, or epidemiological? Go ahead, Jill. Okay. Great, Jill, go ahead. So most of you got this one correctly. This one is something which is quantitative. It is based on data. It's not experimental. It did not attempt to determine causality. So here is an example. Here, there's a little thing here of qualitative research exploring real-world context based on perceptions, considers multiple perspectives, no attempt at causality, use of interviews and observations versus quantitative research, which is experimental research to discover causal or correlational relationships between variables, and it's based on data collection and analysis. Okay, now, Lilo is obviously a very busy person in their facility, and so they did another study where they surveyed parents about their satisfaction with breastfeeding and what type of problems they encountered. What type of research is this? Quantitative, qualitative, historical, or epidemiological? Okay, go. So which sort of research is this? Parent satisfaction and what type of problems they encountered. Okay, Jill, go ahead. So the correct answer is qualitative. Once again, for qualitative, we are exploring real-world context based on perceptions. We're considering, there's no attempt at causality because they're looking at the satisfaction with breastfeeding and what sort of problems they encountered. And I will say that the historical piece is a bit of a sophisticated distractor, simply because you're thinking of, oh, it must be historical because we're asking parents to think about it and to historically respond. But no, the answer is going to be qualitative because we are using interviews, observation, and we're not trying to trying to find causality. Okay, here's the next question. Iron levels are low in breast milk. What recommendation should parents be given? A, supplement with iron drops until the baby begins solid foods fortified with iron. B, breastfeed, no supplementation needed. C, breastfeed and supplement at 6 months with iron fortified foods. D, increase the amount of iron in your diet to increase the amount of iron in your breast milk. Okay, go ahead. Which one is correct? What recommendation should parents be given? Okay, another second or two. Okay, go ahead, Jill. This one was a little tougher. The answer is C, breastfeed and supplement at 6 months with iron fortified foods. So there is no need to supplement before 6 months. Most term babies, healthy babies, is going to have enough iron stores on board. And so there's no reason to begin supplementation early unless there is a reason why to do so. And yes, supplementing at 6 months with iron fortified foods is what is recommended. Iron supplements taken by the parent may produce constipation in the baby. So that's why it's not necessary to increase the amount of iron in the parent's diet. Okay, good. Okay, going to the next one. Vitamin D levels are low in breast milk. What are the current recommendations? A, supplement the baby with vitamin D until solids are started. B, breastfeed, no supplementation needed. C, breastfeed and spend a half an hour a day outside. D, baby should be supplemented with 400 IU of vitamin D daily. Okay, go. What is the current recommendations regarding vitamin D? Now, one thing to remember, okay, go ahead and close it out, Jill. Thank you. So the recommendation is that baby should be supplemented with 400 IUs of vitamin D daily. So according to the World Health Organization, they state there appears to be consistency across the world that newborn infants are at an elevated risk of vitamin D deficiency, and that a vitamin D supplement to exclusive breastfeeding is highly recommended in the primary prevention of vitamin D deficiency and rickets. So it is from the World Health Organization. They should receive an additional supplement of vitamin D. The answer to supplement with vitamin D until solids are started, no, because we need to continue with the vitamin D even after solids are started. And also breastfeed and spend a half an hour outdoors is something which could not be really considered a global recommendation. Remember, the IBLCE looks at global recommendations. And so you don't know where in the world, and I'm pointing, you know, as a northern hemisphere, southern hemisphere, where that baby is specifically located. And so spending a half an hour outdoors per day, if they're in, you know, a very high northern or very low southern hemisphere, may not necessarily provide the recommended amount of sunlight and vitamin D needed. Plus, I also do know that some parents have taken their babies outside for the sun, and unfortunately their baby has become sunburned. So especially if they have fair skin, light skin. So we want to be mindful of that. Okay, now, how old is this baby? Don't start it yet, Jill. Here's a couple of hints. The baby has a social smile. They can lift their head to about 45 degrees, and they can hold their head up for a few seconds, and they can visually search to locate a familiar face or sound. So how old is this baby? 2 weeks old, 4 months old, 2 months old, or 8 months old? Okay, go. So I know you can't see the picture now, but what is your first response? Is the baby 2 weeks old, 4 months old, 2 months old, or 8 months old? And remember those hints. Social smile, lifts head at 40 degrees, holds head up for a few seconds, visually searches to locate a familiar face or a sound. Okay, Jill, this one is a little more challenging. And the reason it's a little more challenging is because some of these behaviors can be seen at both 2 months and at 4 months. The correct answer is 2 months, which is why I threw a few hints in there. Now, if you're just taking a look at the picture itself, it can be a little challenging, but notice that a 2-month-old baby is only going to hold their head up for a very short period of time, and then they're going to pop back down again. Also take a look at the baby's fists. The baby is really tight in fist. A baby who's 4 months old may have a little bit more of a relaxed hand because they're more adept at being able to manipulate their body and themselves than a 2-month-old baby can. The correct answer is 2 months, but I will agree that that was a really difficult question. Okay. So the next question is, which one of the following viruses is most likely to be transmitted to the infant through breast milk from an infected parent? Hepatitis C, herpes simplex virus, varicella zoster virus, or cytomegalovirus? Which one is most likely to be transmitted to the infant through breast milk from an infected parent? Okay, go, Jill. Another few seconds. Okay. So actually the answer is D, cytomegalovirus. So CMV transmission from parent to infant occurs in 60 to 70% of breastfeeding dyads where breastfeeding parent is infected with CMV. However, healthy infants who acquire the infection in this manner are almost always asymptomatic, and breastfeeding should be encouraged. Premature infants and immunosuppressed infants are at higher risk of complications from CMV infection, and there is debate about whether these infants should receive CMV positive breast milk. Herpes simplex virus and hepatitis C are unlikely to be transmitted via breast milk. Varicella zoster virus causes chickenpox and zoster. Infected parents should be encouraged to breastfeed. The infant should be protected from direct contact with skin lesions. So I think it might be good to brush up on the cytomegalovirus. Okay, Tyler's diet is vegan. What would you suggest to ensure adequate nutrition for Tyler and baby? Protein from beans and rice, minerals such as magnesium and selenium from grains, folate from dark green leafy vegetables, B12 from fortified foods, or supplements? Okay, go. What should Tyler do as a vegan to ensure adequate nutrition for herself or themselves and their baby? Okay, thank you. So the correct answer is D, B12 from fortified foods or supplements. And so it is important for the parent to receive additional B12. Tyler, a vegan diet means that they're not eating or consuming any animal products at all. And so it's not protein that the parent and baby need, it's actually B12. Okay, another question here. Got about 3 more to go. The primary reason for providing human milk to premature infants is A, to improve bonding between the breastfeeding, chest feeding parent and baby, B, to assure continued breastfeeding, chest feeding after discharge, C, significantly decrease the risk of necrotizing enterocolitis, D, improve neurological outcomes. Okay, what is the primary reason for providing human milk to premature infants? Is it the bond, to assure continued breastfeeding, chest feeding, prevent necrotizing enterocolitis, or improve neurological outcomes? Okay, Jill, we're not fooling too many on this one. The answer is C, significantly decrease the risk of necrotizing enterocolitis. So while the other ones are important, the primary reason for providing human milk to these babies is to prevent NEC. Okay, next one. A potential risk of skin-to-skin care in newborn infants includes A, respiratory instability, B, sudden unexpected postnatal collapse, C, hypothermia, D, sudden unexpected infant death. So what is a potential risk for skin-to-skin care in newborn infants? Give it just another second or two. Okay, great. So the correct answer is B. Sudden unexpected postnatal collapse is a potential risk for skin-to-skin care in the newborn. So hypothermia, no, because the parent is against the baby's against the parent's body, and the parent's body keeps the baby warm. Respiratory instability, no, the baby is more stable. The breathing is more stable whenever they are skin to skin with the parent. And sudden unexpected infant death is not it, but it's a sudden unexpected postnatal collapse. And actually, it's something that you can find. It's been in the literature since the late, probably since about 2013, 2014, where Ludington, Ho, and Morgan state the first 2 hours of life are the hours of greatest risk, coinciding with the time frame with breastfeeding and uninterrupted skin-to-skin contact between women and newborns is encouraged. And so components for this one, it's important to know there's actually several toolkits which show what the research parameters are and what you can do, and the components of safe positioning should be demonstrated to both the parent as well as to the family, and include that the mother needs to be in a reclining position, not flat. The infant's back is covered and the hair is dry. The infant is well flexed on the provider's chest. The infant's shoulders are flat against the provider's chest, provider meaning the person who is providing this care. The infant's face can be seen. The infant's head is turned to one side. So all of these things are important when a baby, a newborn infant, is skin to skin with a parent to avoid sudden unexpected postnatal collapse. Okay, last two. Now, this hand technique is useful for all infants except premature infants, Down syndrome infants, neurologically impaired infants, or infants with type 3 ankyloglossia. Okay, so this hand technique is useful for all infants except premature infants, infants diagnosed with Down syndrome, neurological impairment, or infants with type 3 ankyloglossia. And some may not have seen this picture. This is what we call an oldie and a goodie, something that can be helpful in a variety of conditions. Okay, go ahead, Jill. So the correct answer is D, infants with type 3 ankyloglossia. So this is not something which you would need to, this hand technique is helpful for babies with premature infants, babies with Down syndrome and neurologic impairment, because it provides the webbing of the parent's hand, actually provides support for the baby's chin, and the index finger and the thumb can be used to improve the intraoral support of the baby's cheeks in order to help the baby to maintain that suck and that suction, and is helpful for any sort of issue with tone, with the baby's oral tone. Okay, last question. Here we go. The World Health Organization guidelines for preparing powdered infant formula recommends boil the bottles and teats for 20 minutes or a rolling boil. Boil the water used for mixing for 20 minutes, a rolling boil. Mix the measured amount of powdered formula and hot water. The temperature for the hot water should be 70 degrees centigrade or 158 degrees Fahrenheit. Or D, store prepared bottles in refrigeration for up to 72 hours. Okay, so what are the World Health Organization guidelines for preparing powdered infant formula? Which one of these is correct? You boil the bottles and teats for 20 minutes, boil the water for 20 minutes, mix the measured amount of powdered infant formula in hot water, making sure it's at the right temperature, or do you store prepared bottles in refrigeration for up to 72 hours? Okay, this may be a question where people might want to study this one. Okay, Jill. The correct answer is C. Mix the measured amount of powdered infant formula and hot water. So boiling the bottles and teats, yes. If you're sanitizing the bottles and the teats, yes, it is something to boil them for a minute, or I think it's like 5 minutes, 1 to 5 minutes, but it's not 20 minutes. And boil the water used for mixing for 20 minutes. So you don't have to boil the water for that long. You just have to get it up to that temperature of 70 degrees centigrade and 158 degrees Fahrenheit. And that actually is right when the bottle, if you're using a tea kettle, an electric tea kettle, as soon as the water gets to that boiling point, that's when it's at the 70 degrees centigrade, 158 degrees Fahrenheit. And that's when you need to take and mix the powdered formula with the hot water at that temperature. And you can store it in the refrigerator for 24 hours, not 72 hours. Okay. Now, that is done. We are done with the questions. Do not fret if you got 1 or 2 incorrect or weren't really sure or questioning. I mean, think about it. You're probably doing this on your phone. I have a strange accent. I may have been talking too quickly. You didn't have a moment to really look, or you pressed the wrong button. So this is simply an indication and an opportunity for you to say, oh, wow, I really don't know this powdered infant formula piece from WHO. Let me go take a look at that. They've got great infographics. And so you can take a look at that. Or quantitative and qualitative and epidemiological. I saw somebody, I think it was Julie, who said, oh, maybe we should make this question a little easier, or maybe you should add some words to it. And yes, we possibly could do that. And I know that picture of the baby, 2 months and 4 months, I know that gets a lot of people. So a lot of people usually will type in, wait a minute, that's not right. So just want to say, yes, I hear you. I understand. And this is an opportunity for you to say, okay, where are the areas that I need to study? Is there anything else, Sekeita, that people are?
Yeah, I was trying to be really, I'm trying to honor and be respectful of folks' time, but I do want to, there's a flagged question that says, can you please go over the ways to reduce the risk of sudden unexpected postnatal collapse? And Angela, you said them.
I did. I said some of them. I did not say all of them. And
But
so no.
I think the issue was that it was so fast. And
Yes,
so
I was fast.
if you can just repeat what
Yes.
you said, that would be helpful. And then we can move forward. And, I do appreciate all the questions. While you are looking, are you ready to say that? Are you ready to go over it?
I'm ready.
Okay, go ahead.
So if you're searching online for this, many hospitals will use what's known as the RAPT, R-A-P-P-T, Infant Scoring System. It stands for Respiratory, Activity, Perfusion, Position, and Tone. And it's performed every 5 minutes for the first 2 hours following delivery. And so the key points of safe positioning include mother or provider of skin-to-skin care is in a reclining position, not flat. Infant's back is covered and hair is dry. Infant is well flexed on the provider's chest. The infant's shoulders are flat against the provider's chest. Infant is chest to chest with provider, not over abreast. Infant's head is turned to one side. Infant's face can be seen. Infant's nose and mouth are visible and uncovered. Infant's neck is straight, not bent. So I will type this in. I know you want to add something else to this, Sekeita, so I'll go ahead and type this into the chat, but go ahead.
No, I didn't want to add anything else. I just wanted to just acknowledge the great questions that we've been getting. So thank you all for that. And this is a lively group, and I appreciate it. So we can just move on to the next section. That would be great. Thank you, Angela. So take a moment and take a breath. First of all, I know that this is a lot of information, and yet we didn't go over everything, right? So you might be feeling like, whoa, what just happened, particularly with those questions. I think that perspective is that take a cleansing breath. Think about what revelations you have from just answering those questions, and also from some of the things that's been shared. And just give yourself a hand for making it this far, right? And so we're going to move to the next section of kind of exam day. And I'm going, in the interest of time, I hope I don't speed up, but I really want to be sure that I capture a few key things before everyone drops off. So, give yourself a hand. I want to just allow you to just take a moment and prepare yourself for the next 30 days to kind of buckle down and get it done, because you started with passion, dedication, and right now it's endurance that's necessary for the end of this part. And so arriving at exam day will be a reflection of that passion, of that dedication, and of that endurance. And so, we want you to get there and get there successfully. So with the next few slides, we'll talk about what that looks like, because there's some key things that you should be aware of. All right, so the last few days, I just talked about this, staying connected to your passion, celebrate your dedication, and trust your preparation. And that involves making sure that you do prepare. Next slide. I want to just be real mindful of the time here. All right. With all things, even with the exam, remember, take a deep breath. The day of the exam, it is nerve-wracking. You really are going to be a ball of nerves, and it depends on some of us have to travel, and some of us will be taking it live proctor, meaning on a computer. So just remember to breathe. It is so important, and I can't stress that enough. The day before the exam, you want to make sure you know what to do. You also want to make sure you know regarding the specifications that are necessary for your computer system. You cannot test on the tablet, and the Microsoft Pro is considered a tablet. Can't test on an iPad, none of those things. You want to make sure if you're testing at home that you have a stable internet connection. Sometimes that looks like doing a hard wire into your Ethernet at home. Know that there will be security measures in check. Know that there will be a preparation check. There's usually 3 security checks. So it is a time-consuming and thought-provoking and intentional setup that you have to set up. You need to make sure that you know what to do if you need to go on a break and when breaks are allowed. Excuse me. In the past, students have been disqualified because they did not understand what to do if and when they needed a break. And so those are things I'm not going to go over. However, I would advise you to go to the Prometric testing website if you will be doing it live proctor. Go to if you're going to be going in person, you want to go to the testing sites website of where you're going to be going to make sure that you really understand so that you don't get disqualified. And the reason why I'm saying all these things is because in this day and age, we're inundated with emails, text messages. The inputs are just coming and coming and coming. And so sometimes when we are reviewing emails, we're really skimming them. It's so important to read every single word of your emails as it relates to test taking and the day of the exam. So Computer system requirements. There are requirements that your system has to have. And I will say that your webcam, for example, it has to be a movable webcam, right? Your webcam on a webcam on a laptop is acceptable as long as you can move the laptop all around, because you'll have to show the entire room. All right, you cannot have more than one webcam in use. You can't have dual monitors. They're not permitted. You want to make sure that your laptop is plugged directly into your power source and not an attached docking station. I'm sorry, I don't know why I said that. You also want to have working speakers, and a microphone is required if you're taking it at home. So really go to the proctoring remote checklist that is on the IBCLC Commission's website, and find out what to do if you have tech difficulties. Because again, you don't want something to happen and then you're disqualified from finishing the exam because you did not simply know what to do in a really time-sensitive manner. In some places, masks are required. Again, you want to check your local testing site to find out their requirements. Now, doing the questions that you just did should have given you a little bit, just a tiny bit of what your exam temperature is. And what I mean by that is think about past tests that you've taken, and think about what worked for you in the past. And, if you feel great about today and you got a good handle, stick with that, go with that. But if you're nervous, and I'm an anxiety. Even if I prepared, I have a ball of nervous energy. Think about the steps that you've taken in the past that help you succeed and follow that. If you feel like I have tons of more preparation to do, don't panic right now. What I would say to you is create a realistic plan that's going to help you, that is conducive to what's going on with you right now in your life. And that could look like, for example, someone said to me recently, I have 3 little ones. How do I prepare? It's hard for me to carve out time. And what I said to them is, okay, that's fair. So what time do they go to bed? And whatever time she told me. And I said, you're probably pretty tired about that time too, right? And she said, yeah. I said, okay, so take your nap and set it. What does it look like for you to set alarm for 3 o'clock in the morning if you go down and you can prepare for 3 hours and be intentional? And so what I'm saying is think about what's going on with you. What worked for you in the past may not work for you now either, simply because life is a little different. Some of us are taking this exam along different life journeys. And so really be intentional about the next 30 days of your preparation. All right, so I love this quote, and I just going to read it verbatim. Many students cannot pass their exam because they fail to sacrifice the minimum capital of time and money. In essence, what I was just talking about was the concept of time, carving out time. And sometimes, yes, money is required to do so. And I actually got this quote from a book that I read when I was sitting for my nurse practitioner exam, and it really made a lot of sense. Of course, I purchased the book, right? That's the capital to kind of figure out, how do I pass this exam on the first time? And so in saying that, please utilize at least the capital of time to prepare for this very important day. Before the exam, you got to plan to be alone. There cannot even be pets. And if you're doing it live proctor, no pets, no people, no one can interrupt you. If that happens, if an animal is seen in the background, or if a door opens and a person is seen in the background, that is automatic disqualification. Please be in an area where the light in the internet is strong, and suggest that everyone stays off the internet. No streaming, no social media, none of that. And again, as I said before, consider a hardwired Ethernet cable, and make sure you just have quiet time, a place that you can it can be as quiet as possible, because this is a timed exam. You know, one of the things you want to do before the exam day, and this is the day before, is build on your own confidence. Do things to put a smile on your face to make you feel energized. Find a podcast or meditation app, anything that helps to center you. I am big on affirmations. I write notes and I put notes all around sometimes in places that I'm going to be throughout the day, walking throughout the day. Those are things that you can do to kind of help calm some of your anxieties regarding test taking. The night before the exam, try not to cram, try to get some sleep. I know that's easier said. Find your inner calm. If it is just deep breathing, it's very slow, deep breaths in and out. Try not to cram. I know it's going to be hard not to do that, but the more you can kind of calm yourself and be confident in the things that you know, the better off you'll be. The day of the exam, don't eat anything special. Eat what you've always eaten in the past. This is not the day to say, okay, I am going to treat myself. You can treat yourself after the exam. You want to make sure that you eat something that your body agrees with. If you are taking the exam off-site, make sure you wear comfortable clothing and make sure you allot for temperature changes in the space. Trust your preparation and just lean into doing your best. And then afterward, grab that special food to treat yourself. The test format is 175 questions. There's 2 parts to the exam. They are all multiple choice. The second part of the exam includes images that are multiple choice. There's a 4-hour duration for the exam, and there's 30 minutes extra if the exam is not in your primary language. Of course, that has to be something that has been prearranged. Each question has only one correct answer. So there's no penalty for a wrong answer other than getting it wrong, right? You have to answer each question. It is to your advantage to answer all of the questions. Work at a comfortable and thoughtful pace. And what I mean by that is when you read the question, make sure you read each and every single word of it. Make sure you read each and every single answer. Eliminate the answers that are, that are definitely wrong and choose the best one. If you feel like I'm still sitting on the fence, answer the question, flag it, and if time allows, you can go back. But you do want to make sure that you move forward at a pace that's going to allow you to complete the exam. First impressions, your first impression is usually correct. Try to resist the urge to second guess yourself. I know in the past I've taken tests and I second guessed myself and I was kicking myself for that. So make sure you kind of go with the urge to whatever your first impression is probably the right answer. Unless you get to have an aha moment and say, oh no, that's wrong. Then of course change it, but kind of resist that urge. Don't read more into the question. Answer the question based on the information given. And I know that is hard to do. Try not to read additional things, the what ifs, the oh, this is left out, because it simply is not, most of the questions are not intended to trick you. They are really trying to determine if you have the competency as an entry-level practitioner or provider, and that's safe for practice. And so try not to read more into it. Answer it based on the information given. Immediate termination or dismissal. You can't leave the examination workplace. The only time permitted for a break is between part 1 and 2. You must alert the proctor before moving away, even if it is between the break. Moving away from the web camera during the break and finalizing the exam. Leaving the view of the web camera without acknowledgement from the proctor, including during your scheduled break, will result in immediate dismissal. There can be no third parties. And I said this, I think I got ahead of myself because I kind of knew what the slides were, but no third party can enter the room. Turning off the light or computer audio, or moving from the original testing location, or speaking to or receiving aid from other individuals is strictly prohibited. Now, when you are done with the test, be confident that you are done with the test. And this slide represents like some folks are done and they're just done, and that's simply okay. Some people are done and they are so confident, like the little person in this video where the fire is like blazing. I guess it's the assumption that this person set that house on fire and is glad. I don't know if I want to give that, but you can set the exam on fire and be happy that you accomplished it, right? Or the confident little person over here, or to the left of me, sorry, to my right, is my work here is done. And so it seems impossible, but you're almost there. When you're done, hit submit. Don't sit there. If you have finished it in 3 hours, don't sit there and contemplate and ruminate. Submit it and be done with it. Resist the urge. So when you take the exam, you are still going to think about this exam, and you're going to be watching the website to see when are the exams, when is it going to be posted. It's usually a couple months before you will know, and I know that's nerve-wracking. Remind yourself you did the best. And then this is the opportunity to try to stay connected with your professional community. Keep learning. This is your time to start networking and planning for your next steps of when you receive information that you have passed and you are now in FILCA. Remember your why. You know, if you don't pass, remember your why. And I'm only saying that from a standpoint of sometimes our best made preparation, our best made plans, they don't come to full fruition. But remember that passion and your dedication, and, you know, continue to strive for your goals along your journey. And I wish you all the success, and thank you for joining us.
I feel better.
I tried. I apologize. We had some good questions. This was a good group, good energy. You all have taught me some things and have informed, you know, this presentation and what may happen the next time we do this presentation. This is the last presentation. We won't be doing another 15-day, just so you know. I think there was a question about whether or not there was going to be another one. And I'm like, yeah, when we do 90-day for the next exam coming up in months and months and months from now. But Angela, what are your last closing thoughts as we leave this group with good vibes and well wishes?
So do take a moment and find the areas where you need to focus, and do focus on those areas. We do have a really good exam review course. There's one that's a basic and one that's enriched. It's got videos that cover all of the detailed content outline. We have over 500 questions in our Q bank, which are questions designed to be similar to the IBLCE questions. And so you can take them more than once, I think only 2 or 3 times before Julie says something to me here. So please do know that we've got you covered if there is something else which you need. So what else do you have, Sekeita?
That's it. Just much success. Prepare, prepare, prepare. Don't be afraid. Don't get discouraged based on some of the questions you answered today. Use that as fuel. Use that as fire. That's a fire that's being lit up under you to get this thing done.
That's it. That's it. Okay, great. Well, thanks everybody for joining us today. Again, if you'd like more information, go to lactationtraining.com and look for exam review. The recording of this session will be on our website, as was the 90 days and counting webinar. So you can take a look at both of those. They're free, and hopefully it will aid you in studying for your exam. Have a great rest of your day. Bye-bye.